Hi, myself is Shalini Bhardwaj. You're watching ITV Networks Medically Speaking. So today we are going to discuss about COVID-19 and heart problems. We have on our panel Dr. SUJAY, who is a senior cardiac surgeon from Sir GANGARAM Hospital, and our another doctor is Dr. MISHRA, who is a cardiologist from All India Institute of Medical Sciences. Welcome to the panel, sir.
Thank you.
So my first question goes to Dr. Sundeep Mishra. Sir, what is the connection between COVID-19 and heart problems? Why so many cases are coming related to cardiac arrest, heart attack?
Okay, I think a very good question, Shalini. I think, one actually classically thinks of COVID as a viral infection affecting the respiratory tract. And we think that lung problems are the main problems. But the reality is that COVID is a viral infection which affects the immune system. Can not only activate the immune system, sometimes it can even depress it. So because of this immune problems, the problems can happen in lungs, but they can happen in heart as well. And as a matter of fact, in some of the series, in one eco series, they had found that even in patients who had not come with cardiac problem, and they did their echo, and they found echo abnormalities in about 70% of cases. And other than that, also through MRI, they did MRI in people who had come with COVID disease, but not having any obvious heart problem. But MRI showed that there was heart involvement in about 80% of cases. So one has to understand that COVID, yes. But these are asymptomatic. They did not come with heart problems, but the virus problems were detected in the heart. So it was like a subclinical or asymptomatic heart problem. But what has happened is that we have to understand that COVID affects the immune system, and immune system can cause damage to the heart. So that damage can sometimes come out as symptoms, sometimes it may not come out as symptoms as well. And not only that, this immunity, actually immune thing causes thrombogenicity also. So which means that the arteries, they have more chance of getting clotting, and therefore we see heart attacks also even after the infection has gone away. What commonly happens is that while there is infection, people focus on lung disease. Then people get better, they get discharged, they become even COVID negative. 2 weeks later, they suddenly come out with developing heart attacks. So they can't understand why did they get heart attack. The reality is that even when virus goes away, the immune system gets activity, and it's like an immune thrombogenic phenomena where the arteries or any vessel can get the clot formation inside the vessels, and therefore people can get heart attacks even after they become COVID negative.
Dr. Shah, sir, how much difficult to handle such cases?
First, I would like to have a conflicting view about the MRI study, which Dr. Saab just quoted, that about 78% of patients who came with COVID had MRI abnormalities seen on MRI. But these patients, number one, they were not symptomatic of any heart illness. And number two, in about 56% of normal population, which was studied later on, the similar abnormalities was found. So really, whether that abnormality is of any importance or not is open to question, and we should probably accept that that study was not really as important as it was made out to be in the beginning. Well, barring that, everything else I agree with, and a lot of our patients are presenting now with cardiac symptoms. In fact, not just heart attacks, but also heart failure. A lot of patients who develop COVID suddenly get into heart failure, where the heart stops pumping as effectively. Part of that is thrombosis, part of that is immune reactivity, part of that is the increased work that the body is doing to control that infection. And as a result, the heart is expected to do as much work. And then when the heart is originally a bit weak, the heart cannot cope and they go into heart failure. From my point of view, from my perspective, we are now having to operate upon patients who have had COVID in the past. So there are patients who are coming with our normal heart disease, whether it is valvular disease or coronary artery disease or aortic disease. So they come with currently diagnosed heart disease. Patient had a heart attack, was diagnosed as critical coronary artery disease, is referred for surgery. And then when we operate upon these patients, some of these patients get into a very violent immune reaction even after cardiac surgery. So we are being very careful, very cautious about these patients who have recovered from COVID. And we take time, we look at their profiles, their immune profile, their inflammatory profile. And if they still continue to produce inflammatory markers, then we postpone their surgeries. Now even the recommendations from various societies have come, and we are aiming to postpone surgeries for at least 6 to 8 weeks after their COVID symptoms have resolved. So it is a changing dynamic. We are learning new things almost on a monthly basis. But now that we have seen a lot in the last 1 year, we are a bit more wiser than what we were 1 year ago.
If somebody is already a cardiac patient and he or she, gets negative after a COVID treatment, so do you think it is required to go for echo or something like that?
Yes, as a matter of fact, actually,
I don't think there is any new record.
Yeah, let me just answer. Then I think we can have his
Yes,
opinion
please.
as well.
Yeah, please.
Yeah. So what I was trying to say was that after developing COVID infection, especially in cardiac patients, there have been some studies which have followed up by doing echocardiography. And they have shown that there is some improvement in echocardiography. Interestingly, as I said, not only MRI, echo study also showed that about 68% had some echo abnormalities. Although these echo abnormalities were dilatation of right ventricle, which was the most common abnormality. Also, not only this, there was an autopsy study also which showed that even in people dying of, lung infections, about 40% had virus in myocardium as well. So what I was trying to say was that, MRI study is not alone. There are other studies also which show that there are a lot of asymptomatic cardiac issues in people who present with something else as well. Now, regarding this follow-up, as Dr. said, there is no clear guideline as of now. But there are some studies which have shown that
because still, sir, if we talk about a common person, he or she doesn't know that, what kind of problem they can face in future. And sometimes it becomes worse.
Yes. So what we are doing is that if people have cardiac problem, naturally we anyway follow them echocardiographically. What the studies have shown is that if echo worsens, then there is a higher risk. So what we generally do is we follow up after some time, do another echo. If there is improvement in echo, we are okay. But if it is worsening, then we do regular echos to see whether that worsening is progressing or it is improving. Another thing that can be done is the D-dimer. Now, again, there is no formal recommendation or guideline, but there are studies which show that if D-dimer is more than 1000, then these people may be at risk of developing a subsequent thromboinflammatory reaction. So these are some of the studies. There is no guideline as of now, but if somebody wants to get something done, these are some of the options. And sometimes we do use, not in the routine case, but rarely, depending on patient severity and other things, we have certain tools which we can look at.
Dr. Shad, what would you like to say about it, sir?
We have standard protocols of following up these patients, and most of the protocols I look at either a patient's symptom. If a patient has a problem, then we look at them. Or if we know that a patient has a disease which is likely to affect his longevity, a disease which is likely to bring the patient into hospital or cause loss of life in the near future, then these patients are followed up more closely. Other than that, as Dr. Sab said, there is no new recommendation as to how we should follow them. But if a patient has had COVID And if they've had any symptoms which are persisting despite clearance of COVID from the lungs, then it is worthwhile to have another check, whether it is by an ECG or an echo or Holter monitoring. And we are seeing a lot of patients coming with a variety of symptoms. It is not just that they get chest pains and breathing difficulty.
Sir, what
Some
are
of them
those
just come in.
symptoms, sir? What are those symptoms basically?
Some of these patients come in with extreme nausea and vomiting. And then on investigation, we find that they've got a myocardial infarction. Some of these patients come in with dizziness and fainting. And there are at least 3 or 4 patients in the last 2 weeks who appeared to our hospital with dizziness and fainting. That was the only complaint they had. And lo and behold, we found that their COVID antibodies were sky high. So they are recovering from COVID infections. They get some cardiac procedure done, and a few days later, they start having faints and all. But most of this business is coming from what we did not know about COVID, but now COVID is affecting the heart as well.
Dr. Sundeep, what are how to prevent such cases?
Yeah, just I will add that there is something called long COVID. And these are the people who, even after becoming COVID negative, may develop, either continue to have symptoms or may develop symptoms even later on. And as Dr. Saab said, some of these symptoms could be heart symptoms or cardiac symptoms, but they can have other symptoms as well. For example, they can have fatigue, they can have, as he said, dizziness, nausea, vomiting, they can have loss of consciousness, they can even have convulsions. So it can be neurological symptoms, it can be chronic fatigue, and all the reasons why that is because of the inflammatory immune response. So that is the reason for a long COVID condition. And previous SARS infection told us that these symptoms and these kind of things happened in the previous SARS infection also, which happened in 2003, if you might remember. And at that time, they found that some of these things could continue for as long as 2 years. So this is not something very new. But this was already known with previous SARS infection, but we are now discovering this with COVID as well. Long
and
COVID.
The shocking part is the young people who get negative, and all of a sudden, they get collapse. And at last, we got to know that our patient has gone through cardiac arrest. So the thing which is important, that is awareness at last.
Yes.
So how to prevent?
People should know. Yeah. Actually, Dr. Saab also said there is no clear-cut guidelines on how to prevent. Number one is that people should be aware. So they should know that even if we have become COVID negative, we still be careful, and we advise restriction of heavy exercise for 6 months. And then depending on the condition of the patient, so some of them may have persisting symptoms. So there are some, it has been found that in at least United States of America, that even after getting discharged, about 80% of the people were still on oxygen. So they had persisting lung problems. Likewise, somebody who was recovered from myocarditis can have recurrent or persisting heart problems also. So that is one group which have persistent problem. Naturally, they have to be careful, get all the tests done and proper treatment also. But there are some people who were not much symptomatic to start with or asymptomatic, but down the course, let us say 1 month after becoming negative, they can develop these symptoms. But there is no way to predict. But all I said is that if there is some high risk people, then you can sort of do a follow-up with either echo or D-dimer. Although again, I have to say again that this is not recommendation, but according to patient. So basically a patient-based approach has to be taken here, not a blanket approach of all the patients, but a patient-based approach. If somebody seems to be at high risk, maybe we can do these things. So this is the way to prevent. And if something is happening, then there are certain therapies available that can be used. For clotting tendencies, we have, NOACs, which are newer anticoagulants, which can be used for venous kind of thrombosis. And for arterial thrombosis, we have aspirin and, clopidogrel, other agents are available. Depending on the risk and depending on how much, risk they have for developing disease.
Dr. Shad, my next question to you, sir. Does it involve some kind of age group?
Age groups are very sensitive, but as you see, when the Italian pandemic struck in the very early part of this 2020, the majority of the people who died out there were older people. And I think because they have a very high, they have a significantly higher population of older people, that's why they had such a high fatality risk. In India, we have a much younger population, and that might be one of the reasons why we did not lose as many patients of the population as the Italians and the Americans did, and the British did. So part of the reason is age spread. Part of the reason also is that our people have been extremely good with the mask, that Indian people accepted the government guidelines. It is also very creditable that our government gave a straight line that you have to have masks and you have to have a social distancing. So it's very nice time for us to be in India, where the government gave a unified message and the people accepted that unified message in a large way for almost a year. It is only now that some people have got fatigued of all this, but still we do not see any angry opposition towards against masking or against social distancing as we have seen in the Western countries. So these are the reasons why we did not get affected. But yes, younger patients have been affected. We have ourselves lost a few of our own colleagues to COVID. And there are any number of stories of young doctors dying of COVID, having cared for a large population of COVID patients. So this is not something that spares anybody. We all must still remain vigilant. Vaccines are on the horizon. Things will get better in a matter of time. And since we are towards the end of this pandemic, hopefully we should remain even more vigilant and not let down our guard.